Everybody's muted. Somebody put in the chat box if you can hear me. Okay, thank you, Lisa. Awesome. I'm going to assume that's a strong confirmatory yes that you can hear me. And then let me share my screen here. Let's go. And okay. Okay. So this is a patient who has had very severe gastritis symptoms. And presented in such a, he'd been having extreme diarrhea, lots of gut pain, really only able to eat a handful of foods. And his initiating event, there had been some episode that suggested maybe food poisoning or some type of gut-based infection. And so then these are the results that came back in terms of looking at what's going on with him. And so as I begin to interpret results, one of the things is that this is just always it can just feel like a lot of information. And as clinicians, that's what we want. We want to know every way the immune system can react to something. Just not too long ago, had a patient who did an IgG test, and from a very good lab, not a lab that I have any kind of complaint with. They do very good work. And based on that test, she took out foods. As we take out some foods, obviously it's customary that you're going to add different things in that you don't always eat as much of. That's the nature of it. And so after doing that, she felt like her symptoms were getting worse. And so from there, so what that appears on face is that, well, IgG testing doesn't work. She did food removal based on this, and not only did she not feel better, she felt worse. But it wasn't per se exactly the fault of the test. It was just more the fact that it was an incomplete piece that was being looked at. And so when we went back and did the P88 that also looks at allergies alongside sensitivities, what we saw was that there were foods that she was allergic to, and these were some of the ones that she'd added in. And so, for us, in terms of practitioners in the functional medicine space, we probably all agree the most important thing you can do is dietary change. And so we want the most specific dietary change that you can make. And so that means, not just sensitivities, but allergies as well. Allergies can create inflammation in general. We always talk about an immediate reaction, but there's room to have a reaction to an IgE trigger even 4 to 6 hours later. So a headache that comes later or a stomach ache that comes later, that can be also mediated by IgE. So if we really want to know everything that's going on, then we have to look at how the immune system is responding to foods, and not just one way, but multiple ways. In addition to that, kind of multiple things that we should look at. What we want is for the patient to be successful when they do something. And so this is why we want to look at multiple ways that we react to food. So here we are on the P88, and what you'll notice is that we are seeing 4 types of ways that we react to things. IgE, which is an allergy, and that is over here in then the very first column. But then also measuring IgG4, and that IgG4 is a unique antibody. And what I mean by that is IgG4, it is very different than subtype 1, 2, and 3, which make up the vast majority of total IgG. And so IgG4 does something completely different. it blocks IgE, it blunts its activity, it creates tolerance to this reaction. And so here in this column, if IgG4 is greater than IgE in terms of absolute antibodies, and that's defined for you at the asterisk at the bottom of the page, but then that means you've achieved immune tolerance and you don't need to worry about taking that food out. So then we look at the sensitivity part as well as complement. And so what I say that to say is that even though we want to have the most information possible, it can often get complicated and overwhelming for the patient. And so that is why, we want to just think, okay, when I get these test results, what do I want to do in general? So for me, my kind of, three-step path in terms of the overall view that I want to take of this test, the first thing I do is I really just look at the overall patterns in a column like IgE and IgG. And so what we see here is he's got a lot of IgE. He's got kind of a more, and that's defined by the Th2 branch of the immune system. He is more what we would call atopic, so we would expect him to be either have or be at increased risk for things like asthma, eczema, and allergies in general. And so, and this also puts people more on an autoimmune continuum. And so in the case of this, so what we know is that when the lows show up, that reference range to make it into the low category, you're greater than 10%. And the test report has that reference range listed on it now. So greater than 10%, meaning that really we should never be making any antibodies to food. So even if you're making greater than 10%, you're still having some level of reaction. Now, it's not until we get even to the upper fifth percentile that we expect to have an overt acute reaction. So what do we make of that? Well, we don't usually want to just take out every food that's greater than 10%, but it tells us that there's a lot of reactivity going on. It tells us that we are more Th2 tipped, and without taking out every single food, things like probiotics and omega-3 fatty acids will be helpful in terms of calming that Th2 response down. And let's see, let me know over here in the chat box. Please put any questions that you have over here as we go. And I'll try to make sure I'm taking a breath every second and or every few seconds or so to make sure that I am getting back to those questions, because I really want this to be time for you and what's going on. So then in terms of okay, so what we see with this patient, he's very inflamed, very gut-based, loose, watery stools. Feel free, Connie, if you want to put any more information about him in the chat box that we should be thinking about. But then when we get his test results back for somebody who is very gut-based, yeah, he's got a lot of low levels of IgE, so he's somebody that I would for sure want to get them on some level of probiotic and omega-3 fatty acids. Then the next thing that I do is I scan the IgG column. And so this is if I were just basing it on the history of having lots of bowel movements all the time and lots of gut pain, I also would have expected more IgG. But, this is why we do testing, to see what's really coming back. And so when I see this presentation, when I say, well, there's not as much IgG as I might expected, what else do we think is going on? And then looking at, again, complement, because we know that that will amplify the IgG response. We don't worry about complement too much unless IgG is also present. So when we look up top, for example, at almond, there's no IgG, even though there's a moderate complement. Well, complement really has to bind to IgG to be more reactionary. So this does not give us nearly as much concern as, for example, cabbage, which was high in terms of IgG, and and also in terms of C3D. It will bind to IgG, it will amplify this reaction 1,000 or 10,000 fold. And that's sad because cabbage is kind of a go-to in terms of something that we think being healing for the gut. We think of vitamin U from cabbage and helpful in terms of gastritis and ulcers. And so a food that we might have recommended as a healthy gut food, in this case, we wouldn't because that appears to be a trigger for the patient. And so from there, okay, a little more TH2 tipped, some level of permeability based on the low IgGs as well. And so we'll be working on the lining. And then from there, I like to now go, it's just easier for me to visualize and easier, I think, for the patient to visualize in terms of the diets. And so we have the less restrictive diet, and then we have the more restrictive diet. And so, of course, that less restrictive diet is going to take out less. It takes out just the high level reactions, and it rotates the moderate reactions that IgG reactions that have any complement present. So this is kind of a small list. He's having really severe GI symptoms. It probably doesn't really clinically meet our needs in terms of where we would put him and with diet. And then when we look at the more extensive list, okay, this is probably getting us more in the direction that we would think for a patient that's having such severe symptoms. Here saying, maybe, and I like to work with 10 to 15 foods, 10 to 20 foods. I mean, um, yes, taking out any food that provokes an inflammatory reaction is clinically the correct thing to do. It will minimize inflammation. However, there's also the realistic parts in terms of compliance of the patient and making sure they do have some diversity in their diet. And so in terms of from the patient perspective, really thinking about, okay, let's concentrate on whatever are the maybe top 10 to 20 foods based on the severity of the patient. So this list more falls in that kind of numerical category. So I would go through this list and then I would ask him, are there foods here that you eat a lot of? Unfortunately, those are the ones they probably need to keep out of the diet more because that increased exposure is a reason that they might have more sensitivities. And then I would look at it and, of course, ask questions. Are there ones here that you think trigger symptoms for you? And so that would help me, if I felt like I needed to whittle the list down some, that would help me whittle it down. Things that they didn't eat that often, I would say go ahead and keep in the diet. Things that they really didn't notice, that they felt, well, let me say that the other way. Things that they knew they had a symptom to, taking those out. And so then kind of customizing from there. Of course, the computer can never generate the perfect algorithm for each person. So we like to give a few lenses of interpretation and then have you, the clinician, look at these and decide which one's most appropriate for your patient. And then the last thing, that third thing, so first, which kind of overall categories are more lit up? Second, what are the particular foods that are most inflammatory? And then third, this immune index. And so this immune index is a cumulative amalgamation or summation of the antibodies that are present from IgE, IgG total, and complement with a subtraction factor if immune tolerance has been achieved. And so then here's another one to look at and say, okay, here's your top to 15 foods based on total antibody calculation. Are there some here that you know to be a trigger? Are there some here that you really eat a lot? Okay, then let's ease up on those foods. And so that's how I walk through and kind of take a lot of data and put it into a more manageable form. There's absolutely nothing wrong with doing none of that and just saying, you know what, I want you on the less restrictive diet, follow this. Or you are more inflamed, I want you on the more restrictive diet, follow this. And so as the patient has come off the foods, he is feeling better. And so step in the right direction. But another thing that I get the feel for when I look at this test is I go, you know what, somebody with this severe GI upset, but not so many IgG sensitivities, it makes me think there's probably a bug present as well. And there were some indications from the history that dysbiosis might be possible. For example, there was a stool test that had been minimally treated but never followed up on to see if there was still something there. So he was having a lot of watery, frequent diarrhea. And so that picture to me, that explosive kind of picture, often makes me think of bugs. And so something like an intestinal barrier assessment, the test that we have in which we measure lipopolysaccharides, this can be a great next step. Those lipopolysaccharides are the things that are shed from dysbiotic bacteria, and that's what we measure, or we measure the immune response to that. And those lipopolysaccharides, that when they basically, as they're shed from bacteria, this is one of the things, along with quorum sensing, that creates virulence, that creates a symptom. So when we get enough of this toxin, if it gets absorbed into the body, then we call it metabolic endotoxemia, because now it's in our system and it's creating toxicity that will contribute to metabolic syndrome. And so if we but if it's in the gut, then can cause local irritation there, cause that cause more the instant, more watery stools like that. Nausea is associated with higher levels of LPS. So a nice follow-up to this, if he'd removed the foods and he's doing better, a nice follow-up to this to me would be next to look at something like the intestinal barrier assessment or some type of stool test, because I think based on how strong his symptoms are, we would have probably seen more food reactions. So there's probably a bug that is there as well. And treating both of those will probably ultimately get him to his best outcome. We do have also stool testing available at Precision Point. And like I said, that intestinal barrier assessment. So let me just pop that back up for a second. Let's look at it again. So a broader question uh, to something like this is that based on his symptoms, both myself and Connie, the clinician that he is working with, that we were both expecting to see more IgG food sensitivities, and so we were a little bit surprised. So when you have that, when somebody is just extremely gut reactive, unless food sensitivities come back than you would imagine, then that's an excellent time to think, okay, what else could be provoking the gut? If it's not foods, what else is it? And bugs are often the answer. And those lipopolysaccharides are a big part of what causes irritation to the gut lining. So other things that are looked at on that intestinal permeability test. Let me also just grab for you, because um, let me grab that intestinal barrier assessment. Um, so here we go. In fact, maybe I'll just, oops. Okay. So, okay, so the here at the website, and just in case you haven't had a minute to check it out recently, for example, we have this education tab here, and there are a number of, for example, references here that And so, for example, like if you, there's some of the common questions that you might have. Patients say, wait, I came back reactive. Why would I be sensitive to something I didn't eat? Or I really want to drill down more on complement. Or what does candida really mean? How do I interpret this IgE? So a lot of frequently asked questions that are here in terms of quick little videos that just take 3 to 5 minutes. But what I wanted to pull up was under the our testing here. Here is the sharing of all that demonstration without turning the share button on. Oh well. Okay. Well, we can go back and do it again. So what I was trying to show you, but I didn't have the, it looks like I didn't have the share button on. I wanted to enter this education tab. If there's some quick questions that you have, here's some blogs and lectures and things about, for example, why is somebody sensitive to something they don't eat, or how can I interpret the IgE portion, or what does the candida tell me? So a lot of references here in terms of pieces that you might be asked. And then here is the advanced intestinal barrier assessment. So this is a great next step. If you just no, absolutely, like this patient is driven by gut-based inflammation, by foods they're eating. I'm going to do this test back and I'm going to figure that out. And it comes back, yeah, there's some positives, but not as inflamed as you might have thought. This is a great next step. And one of the things that can often be an issue when people, like they come in, they're like, I eat foods, I react, I don't feel good. You're like, yep, you have a ton of food sensitivities. And then they come back and they don't have as many food sensitivities as you would have suspected. This can be a great next step. And the reason for that, is there are a few reasons, but one in particular is diamine oxidase. And this is the enzyme that degrades histamine. And we make it in our brush border. We make it in the fingertips of the microvilli. And so let's just say, even no fault of even food allergies or sensitivities. Let's say someone has more atrophy of the gut lining, and this is just, it is very unfair, but this is just the way it is. Some of us come onto this planet with a thicker gut lining, and some of us have a thinner gut lining. And it's a pretty good guess that your classic IBS, IBD patients just have a little bit of a thinner gut lining. So less mucus there, more possible exposure to the immune cells there. And so they just tend to be more sensitive. Well, another thing that's made in the fingertips of those microvilli, if that brush border is more worn down, this is where we make diamine oxidase. And it's the enzyme that degrades histamine. And most foods have some histamine in them. And then even foods that don't have much histamine, as they sit and they degrade, so like leftovers, that will develop more histamine. And so when people are just reacting to things left and right, but yet they come back and their food sensitivities were not quite what you would have expected them to be, this is a great follow-up idea to that, because if your diamine oxidase is low, you're going to react non-specifically to a whole lot of foods, but it's not an allergic reaction. It's your inability to degrade the histamine, and that's what's causing more irritability. Also, you're going to get a nice overview in terms of, is bacteria an issue as well? So we know that zonulin goes up. It tells tight junctions to open. It goes up even before the onset of various autoimmunity. So it's associated with all, just talking to a patient yesterday, and ankylosing spondylitis, and of course, very painful, and really stressing to her how important it is that she stays off the gluten. And she says, oh, I absolutely know that to be true. But I say that because even in something like ankylosing spondylitis, there's an association with an increased zonulin. So that increased gut-based permeability causing inflammation, triggering an autoimmune condition, even things in our back and the bone influenced by leaky gut. And so two major reasons zonulin goes up: either gluten or bacteria. So if you thought somebody should be more reactive and yet they come back with fewer sensitivities than you'd expect, then a great next step is if it's not a food, it must be a bug. So zonulin will go up in response to bacteria, for example. And of course, our immune response, our LPS, IgA, IgG, IgM will go up in response to bacterial infection as well. So it's always confusing when we order a test, and this patient was an example of that. Someone we just expected to be more lit up like a Christmas tree because his symptoms were so severe. And it does turn out that on that previous testing, in terms of a stool test that was done, he did have some dysbiotic bacteria, and and in terms of, and it was treated, but in a kind of not by Connie. This was before he was with her, but treated in potentially more of a minimal way. So there's a good bet that he's still got some dysbiosis there, and figuring out what to do in terms of calming that down will really be useful. Now, he yeah, foods did make him go to the bathroom, so there was some reaction that was happening there. And we, as clinicians, we always like to know, okay, well, what should we do about it? So I just will share with you that one thing that was a nice breakthrough for this patient. So again, this is the patient that we're speaking of. More markers of permeability, and one thing that really made a difference for him was the use of immunoglobulins. And you guys know I'm a big fan of using immunoglobulins. We can get them from a number of different sources. They can be sourced from eggs, from colostrum, from serum. There's prescription immunoglobulins. But I see that over and over, that when somebody is really reactive to foods, and that's a different scenario, not quite this one, but let's say you have somebody that just comes back hyper reactive to everything. And you're like, well, I'm not going to take every food away from you because you need to eat something. How do we handle that? Well, for me, I am, of course, a I'll do like I said, I'll still go through that same kind of drill, looking at which category they're more reactive in, then looking at the diets and trying to find the 15 foods or so that are most important for them to take out, and just concentrate on the most reactive foods, make sure they're more rotating the others, not eating the others every single day, kind of thing. But so in addition to so one of the things that I really noticed in terms of when I started using more immunoglobulins in my practice was that really seeing reactions settle down, calm down. And what do I mean by that? Really, like on follow-up testing, really seeing quite impressive lowering of titers. And so, of course, I was expected to see this. And when we take people off foods, I'm always doing gut-based work alongside that. And I think for most of our patients, we're doing a disservice if we are not doing gut-based work alongside food removal, because I think food removal is only part of it. I think that's why some of the online testing that's out there, where there's no intervention, where there's no oversight by a clinician, it can be sad. So I always am doing the glutamines and the probiotics and various things to rebuild the gut lining. Well, there was a moment in my clinical practice where I started utilizing more and more immunoglobulins. And what I saw was the shift on food sensitivity testing, just really very dramatic with that. Those immunoglobulins are also high in breast milk, for example, and they're one of the things in breast milk that cues the body to calm down and settle down. So when we have these patients that are just too reactive to everything, then some other options there, absolutely utilizing some immunoglobulins. And so I often use IG26. That is, it's an immunoglobulin that's egg sourced. I like this one because it is cheaper than the rest, and I find it to be very effective. But if I have the more sensitive patient, then you're thinking about serum-derived immunoglobulins if they, for example, can't handle an egg source, or also serum are more expensive, so the colostrum derived, which is what this patient utilized, also quite effective. Just make sure they're not having any sensitivities to parts of milk other than, well, to milk in general. And then, of course, like you guys, if somebody's highly reactive to something, I'm going to be utilizing a lot of enzymes. I'm going to be using glutamine, and just read some interesting data about glutamine. Of course, we think of it for permeability, but it has some activity directly on the mast cell as well. In fact, they were looking at various amino acids to inhibit degranulation of a mast cell, and what they tagged them all and measured it, and glutamine was the most effective at interacting with the mast cell and keeping it from degranulating. So a number of positive things that glutamine can do for us. And of course probiotics, and probiotics are really just a go-to in terms of retraining the immune system. Like I always will point to this one study that where they did peanut desensitization in children. So they injected them with low dose peanut to desensitize the immune system. And the kiddos that got a probiotic, lactobacillus, alongside that in desensitization, 4 years out, 82% of the kids that also got a probiotic were still able to tolerate a peanut. If you didn't get the probiotic, you did all the desensitization, but no probiotic, 4 years out, only 4% of those kiddos were able to tolerate a peanut. So it's really strong evidence to me that when we modulate the microbiome with things to desensitize the immune system, injections are one of those, but food removal is another. So it's a really just important reminder to me that modulating the microbiome is a really huge part of this. If we're trying to get those innate lymphoid cells that are there lining the mucosa, if we want it, they get hyperreactive, and we got to calm them down. And of course, removal is one way to calm them down. But again, sometimes we're in this situation where we can't remove everything. So enzymes break all of it down to its smallest little bits possible. Yes, that's not just speculation. There's absolutely data that decreases allergies and sensitivities. It decreases reactivity. On the flip side, there's also data that talks about people who are on PPIs having an increased risk of allergies and sensitivities because they're not breaking those proteins down all the way. They do look weird and unfamiliar. So absolutely the enzymes, the glutamine for a couple of different mechanisms, not just treating the leaky gut, but calming down mast cells as well. And then also seeing some fun research. This is an aside, but also seeing some fun research with glutamine in terms of being a GLP-1 agonist. And of course, you know, celebrities have used these semaglutides, the Ozempics, etc., and made them very popular for weight loss here. And they're very effective. They tell the brain that you're full, and they slow transit time in the gut so that you stay full. But glutamine is also a GLP-1 agonist, and so yeah, I would always be Dr. Agoli, my partner at Precision Point, when I was working with patients in terms of weight loss, he would always say glutamine, glutamine, glutamine. It suppresses the appetite, and I was always like, wonder what's going on there. So he'd figured out it was a GLP-1 agonist at least a good 20 years ago, maybe even before people knew to call them GLP-1 agonists, but very interesting. So probiotics too, some GLP-1 activity. So anyway, there are more ways to, and you know what else makes you have consistent release of good levels of GLP-1? A good gut lining. So when you're more atrophied, you don't do that as well. So again, that's that signal that tells our brain that we're full, that we don't need to overeat. Gut work will often make people gain less weight. And that's not, that's well substantiated in the research, not only if we're using things like glutamine, but the other reason for that weight loss. For example, very good data with certain probiotics in weight loss. There's one called Bifidobacter animalis. That has some great data in terms of weight. B420 is its other name, or it makes it easy to find on PubMed. And when they look at why it created weight loss in both humans and mice, the mechanism of action was decreasing zonulin, decreasing CRP, decreasing IL-6, decreasing inflammation that's causing weight gain. So anytime we decrease inflammation in the gut, it's not uncommon that we see people lose weight. We've had, yeah. I can think of a particular celebrity who utilized our lab testing, and then she was all over every magazine talking about, oh, it's never been easier to lose weight. So yes, it's common to see that too. So we don't have to reach merely for, pharmaceutic interventions in terms of weight loss. A lot of what we do will, of course, help people to be less inflamed, which will result in good, meaningful weight loss as well. And so, anybody have any questions or patients they want to ask about? Any things on the test? I know another question that comes up often is the idea of when do we retest? And I think that obviously and how do we retest? Oh, yeah, let's see. Did I unmute you? Let me try it this way. Okay. Huh. Hey, Jace, are all the participants, even when they raise their hands, I'm not able to turn off the mute there. Let me see.
What are you asking for, Dr. Burdette?
All right. Well, do you guys mind putting your questions in the chat box? For some reason, I can definitely see that your hands are raised, but I'm not. Yeah. Okay. Thank you. So Maureen asks, what about Candida and Aspergillus in terms of interventions and further testing? And that's a great question because it's obvious that we don't have a lot of patients sitting out there eating Aspergillus. We don't have a lot of patients sitting out there eating Candida. So why are those on there? And the reason that those are on there are because that they really trigger an immune response, first of all. The Candida, particularly with food sensitivity. So if Candida is elevated, it means you're having a strong immune response to Candida. And so we want to, and also if Candida is present, it chews up what's called secretory IgA, the lining in the gut that are 85% of the immune system. And when that goes down, you can take out the food, but your IgG titer will stay heightened for a much longer period of time. Even your IgE titer will stay heightened for a much longer period of time because the rest of the immune system is saying, oh my gosh, what's going on here? My first line defense is in the tank. The rest of us better overreact. And so Candida makes proteases that chew up secretory IgA. So if there's Candida and we don't treat it, it leaves those immune allergy sensitivities lingering for a really long time, and people get more frustrated. So by adding that antibody, we can see automatically if that's the case. And so if that is, if your antibodies to Candida are high, it typically means that you have a good load of Candida and your immune system is strongly fighting it. So I really like caprylic acid, like from coconut oil or oregano oil as my choice of antifungals. And I will run them through depending on their other symptoms. So in terms of Candida, do they have a lot of symptoms that also resemble yeast, candidiasis? Do they have brain fog? Do they have bloating? Do they have fatigue? And if they have a lot of those things, then I'm probably doing something like caprylic acid for a good 3 months. If they have some of those things, then at least, if they're more moderate, 6 to 8 weeks, and then just minimal, then at least a 4-week course, because we want to knock that Candida down. Your immune system responding and reacting to Candida means your immune system is responding, but the part of the immune system that responds to that is the Th17 branch of the immune system. And that's the one that's so inflammatory. That's the same one that goes up with COVID. So it creates a lot of cytokines. That's the same one that goes up with irritable bowel disease and rheumatoid arthritis. So Candida can be a trigger for a lot of things, really igniting our immune system more. And so that is why we put it on there, to make sure to treat it. Dr. Wallman is asking if Histio is useful to reduce C3D reactions. And so I would say in an indirect way, DAO is the enzyme, is the diamine oxidase, and that's that enzyme that degrades histamine. And as you degrade histamine, you do tend to lower inflammation in general. So you'll probably decrease triggering of certain cytokines, which can then cause more C3D. But my more specific go-to, like if I just saw, you know what, there's a lot of C3D and a lot of complement here. So I'm seeing a lot of inflammation of this branch of the immune system. My go-to are curcuminoids from turmeric. They're really quite effective at lowering complement and lowering those C3D reactions.
Dr. Burdette, I miraculously was able to unmute myself. And I
Yay!
don't know if my questions are showing up in the chat, but can you talk about really uncommon IgE reactions, onion, for example? Can we change these with long-term strict removal and, really hitting the immune system and gut support over time? And if so,
Yes.
I know this is different for every single person, but what is a tentative timeline? I have a patient who studied abroad in Thailand, Vietnam. She has IgE reactions to cow's milk and gluten, obviously. And she's really okay with avoiding those things long term, but that authentic cuisine brings her so much joy in life that onion
Yeah.
is a really hard one for her to swallow. So I told her that I would talk with mentors and colleagues and get back to her. Right now, I said 12 months minimum.
Yeah, so seems so contrary to what we've learned, because what many of us learned in med school is that once an IgE reaction, always an IgE reaction. And that's really a dated message. And that isn't even what is spoken in terms of very standard positions and like journals, allergies and immunology, or annals of allergies and immunology. Like really, when you go through current perspective, there's an agreement that that's incorrect, that IgE titers do go down with removal. You can have an anaphylactic reaction and remove it and not have it still be present in 10 or 20 years. And interestingly, the half-life of IgE is even faster than IgG. The half-life for IgE is 2 to 4 days. And the half-life for IgG is 21 to even 96 days. You see a range out there. Well, that seems really confusing too. Like, how could that be the case? Well, because that's normal physiology. So if I get stung by the bee and I make some antibodies, an IgE reaction, I want those to get metabolized quickly, because if I get stung by a bee again, I don't want it to be even worse than it was before. So normal physiology is a 2 to 4 day half-life for IgE antibodies. Now, our people have pathology. They're overreacting to things, and so their titers stay elevated for longer. In that worst case scenario, you can have the little kid who has an anaphylactic reaction to a peanut. He avoids it for 20 years and hits it again and still has a reaction. That's not normal, because our titers should decrease over time with avoidance. That's what should occur. And this is, again, not just me saying this. How would there be a whole world of desensitization using injections to decrease anaphylaxis if we couldn't reverse this? So of course an allergist would agree that we can reverse it. That's why they do desensitization injections. It's just that it's not the only way to get there. So I agree with you. I would have said 9 months. I think 12 months is very cautious, and it makes sense, because it's one thing to feel better after removing a food. That can happen almost immediately, within a few days, at least a couple weeks. It's another thing to absolutely retrain the immune system in terms of reactions. And so back to that analogy of desensitization, you don't get to do that for, a few weeks and then you're done. It's done for 2 years usually. And so this, exactly to your point, if we're really trying to retrain the immune system, that part takes much longer. And so, I would also suggest, so desensitization is one way of getting there, and the mechanism of action of those shots are that they increase IL-10, interleukin 10, and that increases production of IgG4. And when there's more IgG4 than IgE, that creates tolerance. Well, other things increase IL-10. So, well, breast milk has IL-10 to make us not reactive to foods. Colostrum antibodies, for example, because they come from breast milk, often have some levels of IL-10 that are in there as well. Um, uh, Probiotics increase IL-10. Omega-3 fatty acids increase IL-10. So while he is off these foods, I would absolutely make sure that he's on a good, robust dose of omega-3s, doing some good probiotics the entire time, because they're really the workhorse of calming that immune system down, retraining the immune system, and not just kind of individual things like that. Like all of your leaky gut work not only lowers IgG titers, but lowers IgE titers as well. Permeability does affect IgE as well as IgG. It's not really one or the other. So when we decrease the leakiness of the gut, when the barrier is stronger, it means, as we know, we tell our patients there's less things leaking in, there's less things triggering the immune system. Well, that triggering of the immune system specifically is that now, or one part specifically, is that blockade means our dendritic cells are like, ooh, I'm not being invaded. Everything's going well. And so the dendritic cell says, yeah, we don't need to be overly reactive, and puts out more IL-10 to just keep everything nice and calm. My lining's not permeable, so all of this must work well with me. Yes, I like what's going on. Here's my IL-10 signal. We can, and so even standard of care says it is appropriate to consider reintroduction of an IgE reaction. Now, based on what their reaction was in the past, I would have different ways of doing this. If they had known anaphylaxis to that food, their lips swell, they get short of breath, any of those things, then that reintroduction would be done at the clinic with an EpiPen around, with Benadryl around, and so that's how I would proceed.
Thank
Well,
you
what about
so
with the
much.
PA?
It's really
Yeah.
interesting. I was doing research into IgE allium reactions, and it's specifically dermatitis, and really commonly dermatitis and hives and wheals, which on her medical symptom questionnaire was like a 7 or a 9, you know? So upon reintroduction, this is what we're really going to be keeping a big eye out for, is documenting skin symptoms. So I wanted to thank you so much for that in-depth answer. Thank you.
Yeah, absolutely. And the other thing that I would just keep in the back of my mind with onion is it's high on the FODMAP list. So you know, sometimes those FODMAP foods people aren't breaking down well, and that's the reason for more irritation. So it would be just a really good idea when she has that lovely Thai dish that's all full of garlic, for sure, taking some enzymes with that meal. Those are good times to take probiotic and even a little bit of like HISDAO, because if we calm down any histamine that's created, then it keeps the gut lining from getting broken. So I would, so consider those things. Now, if somebody shows up with an IgE reaction on the P88, but they don't remember ever having an overt reaction to it, that can be the case. Even with the best allergy test out there, 50% of the time when there's a positive titer, there's not a symptom. So that, and you know, we know this from sensitivities. This makes sense to us. Like it creates inflammation, but there's not always an overt symptom. So something similar could be going on. So so let's say let's say chicken shows up high and they've had chicken and they never noticed an immediate reaction to it. Now, when we're ready to bring that in, I don't necessarily feel the need to do that one under supervision with an EpiPen. If if there was no overt reaction to it before, I think conducting a reintroduction outside the clinic is still medically responsible.
Thank you.
Can you hear?
Yeah.
Can people hear? Hi, I'm Dr. Atusa Kurosh. I'm a pediatric allergist and also functional medicine. And I've been enjoying this webinar. I just wanted although we do allergy shots for almost every kind of allergen, we don't do them for food allergens. And that's because there were many deaths. There were several deaths, like dozens of deaths in the 70s when they tried to do subcutaneous allergy shot injections for food. So all food sensitization was either done through oral immunotherapy or sublingual under the tongue immunotherapy. That's one of the clarifications. Another question I had was about along the lines of doing concurrent P88 along with microbiome testing, which I do often. And I find, for instance, zonulin elevation on the microbiome test, as well as eosinophil, eotaxin protein elevation, that can be measured in at least one of the microbiome platforms that I use. And alongside the P88. And in that case, when there's those elements of inflammation and as well as possibly food-related inflammation, do you still do the rotation or do you do total elimination on the more restrictive diet? Thank you.
Yeah, so if they are, if they're more severe, then the more clinically accurate thing is to do the most restriction that they can tolerate in their diet. You're definitely in that that clinical space of that's most confusing, because with kiddos, you know, for sure we want good diversity and we want to make sure they're getting everything that they need to grow. So I would absolutely, with a high IgE, I would be taking them off that. And if they're very reactive, I would get them off all of their high IgGs as well, as long as it was still something I felt like the family was able to pull off and comply with. Did that answer your question? I feel like I might have missed a part of it.
Yes, thank you.
Okay, okay.
Yeah, I just wondered if pushing me, for instance.
So sorry, it's going in and out a little bit. Will you ask me one more time?
Yeah, so the question that you're
let's see. Maybe, okay, so okay, so okay, I'm gonna go over here, make sure to get to Brittany's question because I know she's had her hand up the whole time and it's been my failure to be able to put the hand down. So Brittany's asking, oh, can we, yeah, oh, okay, I think you got it in. Can we change it with strict removal? And in many people, it is possible. Okay, yeah, okay, sorry. We did that onion question. And then Connie says that the patient she was working with only took half the recommendations. That's probably standard for most patients out there. So she says that where she's at is only because of the diet part. And she had him eliminate all moderate reactions that were also shown in the immune index as a way to kind of add to. That was the patient that only had 3 foods on the extreme elimination, or on the I'm sorry, on the less restrictive, and then a lot of foods on the more restrictive, so a little hard to figure out. So she used the immune index. And I see a lot of people have a very good success with that. Another pediatrician who works a lot with eczema, who uses this, she finds that the immune index really is the one that's helped her break through on a number of kids that have more eczema. And then let's see, anybody else have a last question or two? Okay, you guys, well, thank you so much for being here this Friday. We're going to do this every month. Feel free to email me, and that is Burdette at Precision Point Diagnostics.com. And so if you wanted to send me the name of the patient beforehand, then I can pull up the test results. I'll strip the name off. We'll talk about them anonymously, but feel free. We're going to do this once a month. Also look for some of our gut-based certification courses that will be coming out. And appreciate having your time here today. And always feel free to reach out with me with any questions that you might have. Take care.